Hello and welcome back. We're going to continue with alterations of the lymphoid function. And this is going to include lymphadenopathy, lymphoma, and multiple myelomas. Characterized by enlarged lymph nodes. So this book is pictures from your book, and you can just see this is pretty severe. Got some enlarged lymph nodes here in his axillary area, his groin area, his neck, down the cervical area. Lymph node enlargement occurs because of an increase in the size and proliferation of lymphocytes. Multiplying and multiplying. And monocytes. Nodes are not palpable or barely palpable, so you shouldn't be feeling associated with an inflammatory process or infection, and that's a reactive lymph node, localized, meaning or in the head and the neck areas right here. I'm not going to test you on where lymph nodes are. That's health assessment. But obviously, these are the main areas, the head and neck, the axillary, and the groin area. If there's a problem with somebody and it has to do with their arm, then obviously axillary lymph nodes could be affected. Any bacteria, viruses that come in our mouth and all the lymph nodes in the head and neck can be affected. And anything that may be invasive through a wound in the leg or groin area is certainly going to affect that. Generalized lymphadenopathy occurs less often, and usually seen in the presence of infections, autoimmune. They may indicate a minor trauma or infection, and you'll learn more about nodes. Infection, an invader comes in the body, those generally are up in a few weeks to a month. No. In that. So just write this down. We talked a little bit about them, but we can kind of tease it out a little bit. Number one, lymph node or has some they have a cold, they have the funny nose, and their body's fighting their lymph node. Thyroidism, and can feel some you can think about when you have a patient lymphomas and cancers that affect the lymphatic system, neoplasms, which is cancer, that develop from the proliferation these neoplasms that are occurring in the lymph system. Lymphomas start in the lymph nodes or the lymph tissue. We've talked a little bit about the lymph nodes and the lymph tissues and the lymph organs over here, which you can see. They result from B cells and T cells. So B cells and T cells the has doubled since 1970. So these types of blood cancers are increasing and increasing, and we're not really sure why, but there's some good theories as far as diets, obesity, side, lymphoma, to scary to think about. The second one, viral infection. Cancer group of lymph nodes to another, and the presence of multinucleated cells derived from B lymphocytes called Reed-Sternberg cells. Important right here, circle this, okay? Hodgkin's is the least common of the two types that we're going to talk about. Hodgkin's lymphoma is one of the most common cancers diagnosed in young adults. They tend to have two age ranges when we see diagnoses of are much more prevalent right here. It's a cancer that's most common in white. Originate a predictable pattern, and I'm going to kind of compare the two, but this becomes important. Starts generally head and neck, and then it's going to progress down there. And as far as clinical manifestations, I think I have a slide. Yeah. Enlarged nodes, B symptoms. B symptoms are important for you to understand. Remember, these are B cells. So symptoms, they're just kind of system, fever, weight loss, ask your pets. Okay, so Current infection is all around their skin. Causes a histamine release. Keep in mind. And this picture right here gives us an indication of some common and uncommon lymph nodes in Hodgkin's lymphoma. And the common ones are the red and the uncommon are the blue. So common lymph nodes are affected: head, neck, axilla, groin. And then there is some lymph nodes, retroperitoneal, located because of their weight, but certainly the spleen is over here, and that's what you want to feel over on the left side under the rib cage, the rib cage. So evaluation and treatment depends on what the stage is, okay? So depends on the stage as far as are kind of used up, and those are later stages. A CAT scan, we want to get a CAT scan. Once they get diagnosed with it, to monitor the progression. Diagnosis: presence of Reed-Sternberg cells in a lymph node biopsy. So lymph node biopsies are typically needed for this, and then they see these certain kind of cells that I think I showed you up here, right here, which are these Reed-Sternberg cells that are specific for Hodgkin's lymphoma. Staging is determined from a physical exam, blood test, radiology studies, the PET scan, and the CT. Biopsy and examination of bone marrow is often but not always done. Radiation, you can radiate a node, and then some chemotherapy that will travel through the body. This can be cured with early detection and treatment. The second one I want to talk about are the cancer of the lymph nodes. The non-Hodgkin's is a little bit more common. It also can originate in the T or the B cells. It has a poorer prognosis than A. Take a look at that lymph node biopsy. There are no Reed-Sternberg cells in the lymph biopsy. So the best way to learn these two is to compare the non-Hodgkin's lymphoma to the Hodgkin's lymphoma. So nodal involvement. So Hodgkin's lymphoma is localized. It travels in an order. B symptoms are common. Extranodal involvement are rare, meaning lymph nodes top node is, they have it in their head and neck, maybe to their axilla, but it doesn't just spread rampantly through the body. It will, but this is just kind of how it starts. So that kind of makes sense as far as this is the prognosis up anywhere. It's not non-contiguous, so you may have one in the head, you may have one as common as this, but it's still, I would just put B symptoms and keep that in mind with any of the cancers, leukemia and lymphoma. But this is really mostly what we see. But again, this can be misleading. This doesn't say they don't have them, it's just not as common. Extranodal involvement, common. Extent of disease, rarely localized. It's spreading out in an unpredictable fashion right here. So prognosis. Let's take a look at staging. So staging, staging equals spread. When you stage lymphoma or tumors, that is indicative of spread. Group or one part of the tissue. Watch that area a little bit and done. Okay, one and done, get it out. That's why catching this stuff early is important. And on all your understand somebody or how you want to refer them if it's something that becomes more difficult. Cells are in one part of the tissue or an organ and the lymph near that organ. So stage 2, it may be in 2 groups of lymph nodes and it may have progressed to organs that are close to that lymph node. Diaphragm. This one is not. This is same side, same side. Draw a line here. More spreading above and below the diaphragm. Lymphoma cells may be found in one part of the tissue or an organ near these lymph nodes. May also be found in the spleen, right? Moving around. Now we see some in organs like the spleen. See right here? Started here, spread to a second group. Now it's spreading down here under the diaphragm and can go to an organ like the spleen. Stage 4, which is the last, lymphoma cells are found in several parts of one or more organs or tissues, or the lymphoma cells are in an organ and in distant lymph tissues. This to other organs, and now some other organs there. Other organs. And recurrent means the disease returns after treatment. So it is important to understand 1, 2, 3, and 4. And again, it's pretty easy if you kind of draw a line right here and know that 4 is the worst, and that has moved into. Let's move on to multiple myeloma, which is now actually has its own little title, which is plasma. Are multiple myeloma and can't blood. So plasma cells here. It's a proliferation, right? Proliferation again, multiplication of plasma. and it continues to just excessively and excessively multiply and excessively multiply. This one clonal cell, and it multiplies and multiplies, and it multiplies in a negative way or in a bad way. So it's a mutation, and it produces a monoclonal body. And so these plasma cells make antibodies. They're actually B cells. When they have this neoplastic proliferation, these abnormal cells make abnormal immunoglobulins or abnormal antibodies, and these abnormal antibodies cannot fight infection. So let's take a look at these pictures right here. I showed you this picture right here. This blood stem cell either turns into a myeloid stem cell or a lymphoid, and we talked about that. The myeloids turn into the red blood cells, the platelets, the granulocytes. Lymphoids. So we talked about this already, so that makes it a little clearer for you. Differentiation, it turns into plasma cells. Plasma cells produce immunoglobulins, which are antibodies to fight infection, and they are shaped like a Y. And you know these immunoglobulins as IgG, IgA. So it's the IgG and the IgA that becomes affected. Okay, so this is normal over here. This one, this makes this abnormal antibody, a paraprotein is what it's called, and this becomes important because these antibodies cannot fight infection. Okay, so they don't have good infection fighting abilities. Infection leads to, okay, if they're proliferating inside, there's not extra space in there. So that bone destruction leads to hypercalcemia. All remember, most of our calcium lives inside the bone. So as these proliferate, the calcium gets spewed out into the blood. We draw their blood and we see, your calcium thing serious. It's getting pushed out. Bone destruction leads to hypercalcemia and pathologic fracture. Somebody gets a fracture and, oh, I got a fracture in my wrist. What did you do? Nothing. I never fell. I never did anything. A pathologic fracture, because what's happening, this is making in the bone marrow, so the bone is becoming very hollow. The calcium's coming out. It's just becoming more porous, and they just have a fracture in their wrist, and they don't even know why. This abnormal protein right here is called an M protein, and we can draw an M protein from somebody's blood. And if the M protein is high, there's an indication that there's some abnormal antibody production going on. My hypercalcemia. So hypercalcemia M proteins clog up they become anemic. Symptoms of multiple myeloma: hypercalcemia, renal dysfunction, anemia, bone pain. They manifest with bone pain or a bone fracture. The hypercalcemia and this process results in the release of calcium, hypercalcemia in the blood, emia, blood, of lytic fractures. So these guys come in and they say, oh, you know, I have this pain in my back and I don't know. And that's just the beginning of the demise, and it's something that gets worked up with that. A definitive diagnosis requires a bone marrow biopsy. We get some lab. We can draw for an M protein. We can draw for the IgG, the IgA, and the IgM. Remember those normal number of healthy plasma cells, those normal antibodies that the plasma cell makes. They're going to abnormal proteins. So healthy bone marrow, normal number of healthy plasma cells, and normal antibodies. B cells turn into plasma cells. There's a normal plasma cells and a normal Y-shaped antibody, the IgG, IgA, IgA. Can cause harm to the body in the bones, in the kidney, hence the renal failure, and in the blood, hence the anemia. Progressive disorder and is often preceded by a condition known as undetermined significance. Multiple myeloma. That's why I have a slide on this. I want you to at least know what it is when you hear it. MGUS is protein, which we just talked about, in the blood or urine without evidence. 1% of the general population, and in 3% of individuals old, they have some abnormal. Although MGUS is considered a benign condition and requires no treatment, percent of individuals with MGUS progress to to asymptomatic multiple myeloma. Right here, the MGUS, 1% of people with MGUS per year will go on to develop myeloma or other blood disorders. Okay, so this 1% of people will go on to develop multiple myeloma. This is myeloma will be diagnosed each year. This is another one, the smoldering multiple myeloma. The risk of progression from this to myeloma is 10% per year. This is just is common, but both of these can lead to multiple myeloma. So that's important to know, because sometimes you see MGUS in a patient's history and you're like, what is MGUS? Just that's it. And then after this, I have one more lecture for you. I know this has been a long chapter, but again, it really is.